spinal. So what you do is in the thoracic spinal, the spinal cord is positioned very much anteriorly, leaving a significant space between the posterior dura and the spinal cord as shown between the arrows. You can see here this arrow, this white portion is the CSF, and you can see the spinal cord is almost touching the body of the vertebral bodies, posterior aspect of the vertebral bodies. It is aligned here, whereas when it comes to lumbar, it is much more in the center or towards the posterior ligamentum flavum. So the space is very narrow. So in that space, if you inject naturally by capillary action, it will spread. Whereas here in thoracic region, one is the curvature of the thorax, as second is the potential space that you have between the uh, uh, ligamentum in the posterior dura and the spinal cord itself. So the fluid stays more here because there is no pressure there to spread it upward or downward. It is like a sausage where it is deposited into the CSF and stays within the area where you go inject. And you have to be very careful with the volume so that if you want a total spinal, you can inject the large volumes of say 4 ml of all the 0.5% bupivacaine and make it spread to both areas. So you have to select the right volume and inject it in the right space so that it stays only in the thoracic region and produces what is called the so far the segmented spinal. So the space between the dura and the spinal cord in the thoracic spine measures about 7.5 millimeter at T5 and 5.88. As it comes down, you can see that gap becomes lower, 5.88 at T10. So intrathecal injections at mid-thoracic level may have a maximum safe distance for the spinal needle contacts to the spinal cord tissues. So the direct damage to the spinal cord by the spinal needle is very much lower in the thoracic region. Contrary to what we have been thinking all these days, you think you can directly go and hit the cord and produce a damage. That is not true in thoracic region. It's much more common lower down rather than in the thoracic region. The smaller number of nerve roots are covered by anesthetic within the subarachnoid space in the thoracic segmental spinal anesthesia and providing maximum surgical field dermatomes. Since there is less block of the lower extremities, a large portion of the body does not experience venous dilatation. This is the biggest advantage, which may compensate for adverse effects in blood pressure intraoperatively. Now coming to what are all the indications for this are the thoracic spinal anesthesia is demonstrated as a safe and effective method, contrary to earlier belief that if you put a drug in the thoracic vertebral space and then in subarachnoid space, immediately your cardio accelerator fibers arising from T1 to T4 will be blocked and patient will have severe bradycardia and may even have arrest. All that has been taught earlier, so we were worried about giving any injections in thoracic region. But it has not been proved to be so. So you can have a spread, but you have to be very watchful and cautious that there may be a bradycardia. So you have to be very watchful and correct it immediately. A simple atropine injection will take care of all that and will prevent any severe bradycardia and asystole. And so this has been considered as a safe and effective method for laparoscopic polycystectomies, breast cancer, lumpectomies, and even abdominal cancer surgery. That is where I asked you about the resection and gastrectomy for a gastric carcinoma. You can even do that under segmental epidural or segmental subarachnoid injections. And the contraindications are absolute contraindication is patient refusal or lack of consent, local infection, and true allergy. These are common for all procedures. Wherever you use local anesthesia, this is a very common contraindication. Patient first of all should agree there should be no local infection and there is no proven earlier allergy to local anesthetic drug. And patients who have elevated intracranial pressure, There also sudden drop in pressure may happen, and coning may happen. If you do that and you let out a lot of CSF, a sudden coning can happen because of that, and the increased risk of uncal herniation. That is what they call as coning, and CSF is lost. So it is one of the important thing. A patient with a known intracranial tumor do not attempt any thoracic segmental spinal. The relative contraindications, if the patient has already some neurological deficit, sepsis or severe hypovolemia or coagulopathy, they are all considered as um, uh, relative contraindications. And of course, there's a question about that, what drugs to be used. You can use, as we rightly said, uh, hypobaric or not hyperbaric is not preferred for this. Hypobaric local anesthetics, and ropivacaine is a very safe drug. Levobupivacaine or ropivacaine, which are available as isobaric preparations, are the best drugs for this. And did we discuss about um, analgesia? That part is we have not come at so.
No, not it, sir. Not it, sir.
Okay, then I will stop here.